As far as the CDK4/6 inhibitors, which are used very commonly in advanced breast cancer, ER-positive, HER2-negative breast cancer, we first put palbociclib on the pathway as that one was approved first, and then as the other two CDK4/6 inhibitors were approved, we looked at whether to add them, whether or not to add them, what sort of differentiation to put into the pathways. So when ribociclib came out, we certainly looked at it. It had similar efficacy to palbociclib. The concern was that it had some additional toxicity that palbociclib didn't have. And since it didn't add anything in the world of efficacy and it added liver toxicity and cardiotoxicity were a little bit higher, we decided not to add it to our pathways. Providers can certainly use it if there's a reason to use it, and sometimes there is. They just have to go off pathway to do it. When abemaciclib came out, on the other hand, we did end up adding that as an alternative because the toxicities are so different. For someone that has a lot of pancytopenia on palbociclib or pre-existing pancytopenia, abemaciclib can be a better option since it tends to affect the blood counts less. Obviously, it can cause more GI side effects such as diarrhea, so that is certainly mentioned. But at the moment, palbociclib with various endocrine agents and abemaciclib, both monotherapy and with various endocrine agents on our pathways, but ribociclib, people go off pathway.
Thank you so much.
We measure success for clinical pathways in a couple ways. So one, we have monthly reports that go to each disease center, as we call them. So mine being breast oncology, and that report will have for both the group as a whole, what percentage of time do people use pathways. When you started someone on a new regimen, you went in and you clicked through pathways and said what was used and completed that process. And we obviously like to see a pretty high utilization rate. We like to see that at least 80%. And then we'll look at it for individual providers as well. And as you might guess, some providers are excellent. They use it every single time. Others are a little less consistent, and we remind them about the importance of using it. And then we also will look at, as I mentioned before, the use, the on-pathway rate. So usage rate is how often you click in and use it, and the on-pathway rate is how often did you use what was listed in pathways and how often did you go off, such as using ribociclib or using the regimen I mentioned before, pertuzumab added to eribulin and trastuzumab. And no one gets punished or reprimanded for going off pathway, but we look at the reasons why, we make sure they're appropriate reasons, and then we will discuss that when we review pathways to see if there are things that we should be adding, we should be doing differently. For first-line metastatic ER-positive, HER2-negative breast cancer, although we had Taxol listed, we had a lot of people using capecitabine. So we discussed this. This was probably 6 or 8 months ago, and the decision was that it was good to have capecitabine as an option as well. There are a lot of patients that didn't want to start with IV chemo. They didn't want to lose their hair initially. So some of them had neuropathy from other treatments or were worried about neuropathy. So based on the off-pathway rates being so high for capecitabine, we ended up adding that as a first-line regimen. So that's an example how we will look at that data and then use it to make our pathways better. We evaluate our pathways on a regular schedule, and we will have additional meetings whenever new data or drugs come out. We typically have, in breast oncology, we have 3 meetings a year, and most groups have somewhere between 2 and 4 meetings a year, just routinely scheduled. We tend to schedule 2 of them after some of the big meetings like ASCO and San Antonio, when breast treatments often are announced, and then we have a 3rd meeting just kind of more mid-year to look at our pathways overall. But we will set up additional meetings when new drugs come out, and typically within a few week notice we can set up a meeting to review this new drug approval and where should we use it and how should we use it. So I think we've had maybe 4 meetings already this year. We're only in June. So one was a regularly scheduled meeting after San Antonio. One was to discuss 3 new drugs that came out, tucatinib, trastuzumab deruxtecan, and sacituzumab, all were discussed. And then the other extra meeting was we recently created an inflammatory breast cancer pathway. So we had a few meetings about that. One kind of initial brainstorming meeting, if you will, and another to finalize the inflammatory breast cancer pathway. So we will add extra meetings anytime there's a new drug, new study that we should incorporate, or if we're just trying to build a pathway for a new treatment situation, such as inflammatory breast cancer. So we have often. We often have meetings. We have standing meetings we can add this to, or we can substitute the agenda for a pathways discussion instead of a standing meeting. So that's what makes it very easy for us to do this. The pathways leadership for the Institute as a whole, David Jackman he's a thoracic oncologist, and he heads our pathways team. He has worked with payers both regionally and nationally to look at how the pathways help guide our treatment, more cost-effective treatment, more kind of guideline treatment. The individual physicians such as myself, even though I'm the breast oncology pathways leader, are less involved with that, but from an institute level, Dave Jackman and some of the other leadership at Dana-Farber have been talking to different payers who are excited about the use of pathways for that particular aspect.